Thank you so much. Hopefully everybody can hear me okay. So some of the things we're going to talk about today, why breastfeeding is important, the New York State and Northwell, where we are in terms of breastfeeding. I'm going to go over some basic anatomy and physiology of breastfeeding, talk about the impact of maternal hospitalization on the couplet, how we actually support our lactating patients. We're going to go over some pumping information. We're going to talk about medications and diagnostic tests and how you get lactation support for your patient when you need one. So one of the things that I think is really important is why we're doing this right now. And August is National Breastfeeding Month, and the United States Breastfeeding Committee sets up a theme each year. This year's theme is Forward Together. And the theme is about systems and organizations and policies working together to advance lactation support in what we call the first food field. And what I want everybody here and on teams to know is that we are truly together. There is a really outstanding lactation team in this building. We're small, but we're awesome. And we're here to support those people that don't know exactly what to do, and we're here to help you and guide you. And one of the reasons this is important is because when you work outside the maternal child obstetric and neonatal service, you don't really get regular opportunities to care for patients who are lactating. You might have limited knowledge in the physiology and management of lactation. You might have a limited understanding of the risks of short and long-term disruption to the breastfeeding relationship. And this happens a lot. People substitute their own experience or what they've seen other people do in place of evidence-based care. So hopefully I can help sort this out today. So I decided to try something a little interactive. So if you're here, you can take out your phone and scan the QR code, and if you're on Teams, what you're going to do is text the message 4324 and the unit that you work in to 37604. So you're texting 37607, and you're going to type in 4324 and where you work. It's working. Yippee! All right, that's great. So you can see we have a bit of representation. Ooh, more coming in. Thank you. All right, I'll move on. Uh-oh. So just over the last few months, these are the places that we've been called to. A lot of different areas throughout the hospital. So we're primarily in the maternal child service in OB, but we go everywhere. And then just like for a little perspective, I thought I would share just volume. So, in 2024, there were over 25,000 newborns admitted to the Well Baby Nursery. And 85% of those families gave breast milk to their baby. So when you think about it, that's 21,000 breastfeeding families in Northwell. And for our site in 2024, there were more than 4,400 breastfeeding families within our hospital. And as a side note, as of March of this year, there are only 1,091 lactation consultants. The International Board Certified Lactation Consultant, which is the highest credential in lactation consulting. There's just over 1,000 in the entire state of New York. So there aren't a lot of us to go around. All right, so let's start with some anatomy. This is a breast. The nipple, the areola. And one of the things I always want to make sure I point out is that it's called a tail of Spence. Breast tissue extends into the axilla, so it's very common for women to have fullness that extends into their axilla. Inside the breast, if you look at it, now the people that know me know that I'm a vegetarian, but it looks like broccoli, doesn't it? So you have a lobe of ducts and your glandular tissue. And at the cellular level, there's an alveoli cell where the milk is made. And that alveoli cell is surrounded by myoepithelial cells, which contract in response to hormonal releases from nipple stimulation and push the milk out through the lactiferous ducts, which are like the stems. And those ducts terminate on the nipple face, where the milk comes out. These are the phases of lactation. The first phase, mammogenesis, is the growth of breasts from infancy through puberty. The second phase of lactation was historically called lactogenesis 1 and 2. It's recently been renamed to secretory differentiation and secretory activation. So secretory differentiation, or lactogenesis 1, these are the functional changes of the breast during pregnancy. So this is the ductal and glandular tissue proliferating inside the breast to prepare for milk production. What women experience is changes in their breasts, getting larger, getting darker, more veiny. The second phase happens, or the second part, secretory activation, occurs a few days after delivery, typically on day 3. And that's a hormonal change that leads to fluid shifts. And this is the increase in milk volume that women typically look for. But one of the things that those of us that work in the OB service know is that there's milk in breasts even when she doesn't feel it, especially those first couple of days. The third phase, galactopoiesis, is the maintenance of milk production. And then the final phase, involution, is the process of weaning or ending when the breast begins the process of stopping milk production. Ooh, another poll. So this is just a true false, same code you would text your answer to. Milk supply depends on food and water intake. I got a true. It's anonymous, so don't feel like you don't want anybody to know what you said. All right, I'll keep going. This is false. Probably one of the most commonly misunderstood things about milk production. So there's a lot going on this slide, and what I would like to do is really kind of break it down. So the analogy that I use all the time when I'm teaching people that are not familiar with lactation about milk production is I will talk about a freezer that's making ice cubes for you. Hopefully you have one, right? It's automatic, it makes the ice cubes, and it falls in the bucket. And then what does it do when the bucket gets full? It stops making ice, exactly. And this is sort of fundamentally, at a very basic level, how the breast works. As it fills with milk, it signals to the body to stop producing it. So now you're having a party tonight, and you need a lot of ice. So what do you do all day long? Empty your bucket over and over. So which freezer makes more ice in the day? The one who's full of milk all the time, or the one who's constantly being emptied? Emptied, emptied. Okay. The other difference is that what the breast also does is it makes milk more rapidly as the breast is emptier. It responds with speed. So the rate of production is greater when the breast is emptier. Hormonally, when the nipple is stimulated, there are two hormones that the brain releases in response to that stimulation. Prolactin is the milk-making hormone, and oxytocin is the milk-releasing hormone. So in order to make milk, you need prolactin. And to build your prolactin levels, you need nipple stimulation. And the more nipple stimulation there is, the more prolactin the mother makes. This is why newborns feed so frequently, especially in the first couple of days. Oxytocin is what releases the milk from the cells. And it is not only triggered by nipple stimulation, but it's also triggered by thinking, seeing, and hearing the infant, or even somebody else's infant, if that's ever happened to people. It's inhibited by physical and psychological stress. So now, once we move into the secretory activation phase, so now we are at a point where her larger volumes of milk are coming in, and she feels her milk. Her milk production is completely dependent on her milk removal. And I said this before, there's a positive correlation between the degree of breast emptying and the rate of milk synthesis. So the more she empties, the more she makes. There is also something in the breast milk called FIL, the feedback inhibitor of lactation, and it accumulates in the milk between feedings to block the action of prolactin to adjust her milk supply to the newborn's demands. So the baby is the demand, and the mom makes the supply in response. So what happens when she is now hospitalized? We have to think about physical considerations, a decrease in milk supply, which is associated with a shorter duration of breastfeeding, breast fullness and discomfort, an increased risk of mastitis, which is a breast infection, which I'll talk about more. We also need to think about maternal health, mental health considerations. There are lowered feelings of competency. Sometimes moms lose their sense of self-efficacy. I can do this. There's an effect on their bonding and attachment behavior potentially. Feeling helpless, feeling a loss of control, that's just part of being hospitalized. Separation also impacts the newborn. Babies who are separated from their families cry more. They have higher stress levels, cortisol levels. They might refuse breastfeeding. Older children experience anxiety and abandonment. So, why does it matter? What's the point? Can't we just feed them something else? We sure can. But what I want to sort of point out to everybody here, if you're looking at this slide, what's the difference between formula and breast milk? So when you look at this, you might first see, well, there's more in breast milk than there is in formula. And that's true. Both breast milk and formula provide water, protein, carbs, omega-3s, fat, vitamins, minerals, nutrients that they need. So what I want you to recognize is that both breast milk and formula are a source of nutrition. But what are you getting from breast milk? What is a mother providing her newborn from her breast milk that she can't provide with formula? Enzymes, growth factors, antibodies, hormones. What I hope jumps out at you is the fact that breast milk is more than a source of nutrition. Breast milk is a living tissue that contributes to the optimal growth and development of human babies. As a result, when babies are breastfed and when women breastfeed, there are significant health benefits. Breastfed infants and children have a decreased risk of asthma, obesity, diabetes, lower respiratory disease, otitis media, sudden infant death, GI infections, necrotizing enterocolitis for the preterm babies. When women make breast milk, they decrease their risk of breast cancer, ovarian cancer, type 2 diabetes, and hypertension. And in 2016, I appreciate this graphic. The Lancet published a study about breastfeeding, and they found that each year of breastfeeding decreases a woman's chance of developing invasive breast cancer by 6%. Because of these profound health benefits, every organization that advocates for the health of women and children recommends exclusive breastfeeding for 6 months, continuing breastfeeding as solids are introduced around 6 months, and then for 2 years or more. Ooh, a poll. So again, you're going to text 37607, and you're going to send your code. How do you think New York State does compared with the rest of the country when it comes to giving formula in the first 2 days of life? Do you think we do better than the rest of the country? About the same as the rest of the country? Or worse than the rest of the country? I don't see, it looks like results are coming in, but I don't see them. Right? Let's see. Oh, thank you. Okay. Here is some information from the CDC Early Childhood Nutrition Report in 2025. This information is based on babies born in 2021. So when it comes to ever breastfeeding, we're a smidge better than the rest of the country. When it comes to breastfeeding throughout the first 12 months of life, we're a smidge better than the rest of the country. It's pretty good. When it comes to exclusive breastfeeding, we're a little bit better than the rest of the country. Look at us go. But when it comes to giving formula in the first 2 days of life, New York does worse than the rest of the country. However, when you look in this document, of course I did, we are not at the bottom of the barrel, which is wonderful. Back in, I believe it was 2020, which a few years ago anyway, we were the second to worst, and we've gone up. We have improved in the last few years, so go New York. The New York State Department of Health has issued the Breastfeeding Mother's Bill of Rights, and we are required to give this document out to all the families that come and deliver here and every birthing facility in the state of New York. And obviously, I'm not going to read the whole thing, but I am going to call out that one little section, which says, if you or your baby are rehospitalized in a maternal health care facility after the initial delivery stay, the hospital will make every effort to continue to support breastfeeding and to provide hospital-grade electric pumps and rooming in facilities. So your lactating patient comes. She is separated from her baby. Her infant feeding routine has been disrupted. So her milk removal has been disrupted. It's less frequent. Her milk supply is at risk. That risk is compounded by medical conditions, by medications, by physical stress, and emotional distress. So what do? We protect the mother's milk supply with timely initiation of milk expression. And one of the things that I definitely want as a kind of takeaway for everybody is that there is a system policy that guides this. You can get it 24/7. It's the Patient Care Services 1613, Human Milk Management and Administration of Expressed Human Milk. What you need is a bunch of equipment. Cass Women's Hospital will bring you a breast pump kit with a built-in wash basin. They'll bring you breast milk storage containers to get her started, and then additional breast milk storage containers as needed. What the other outside units need to provide are the identification labels, some blue chucks, a bedside refrigerator. Cass Women's Hospital does not have refrigerators to supply the hospital. If you don't have a refrigerator in your unit, the family can have a cooler bag with an ice pack, and the milk can stay in there for 24 hours safely. The family can just take the milk home. Milk should never go in the unit pantry refrigerator. So one of the things I just want to mention is that this, in the center, the sterile hospital breast pump kit, the kit comes with a built-in tray. That clear square box is actually meant to be the basin for washing pump parts. And I'm going to explain how that came to be. The basics of using the breast pump: frequency. If she has a newborn or a young infant, she should be expressing at least 8 times each 24-hour period. If she has an older infant, her expression should mimic, to the best of her ability, the feeding and pumping pattern she had at home. One thing to remember: it's never too soon. She can pump her milk anytime she wants to, or if she feels the need to. She never has to wait. Ideally, she's going to pump both breasts at the same time until they are well drained, but up to 30 minutes. We recommend letting the pump stay on for 1 or 2 minutes after the milk really slows down. Shorter times are okay if her breast feels relieved. If she can't get comfortable in 30 minutes, we don't increase the duration of the pump session. Instead, we increase the frequency. While she's pumping, the strength of the suction should feel like a pull or a tug, and it should not be painful. Every woman feels differently. Some people can tolerate very high levels of suction, some can't, so there's no right number. We don't say start on 3 or go to 6. It's see how it feels and adjust to your comfort level. It's important to know that more suction will remove milk more quickly at that pump session, but it won't help her body make more milk. Breast shields come in different sizes. This is a very hot topic right now in the lactation world. The smallest size that will fit her nipple in the tunnel is the way to go. If she needs a custom size, the lactation team here has access to them, and we can size her and provide those custom sizes. All right, labeling, storage, and handling. Again, part of our system policy. Every container of milk must have a patient identification label on it. If the newborn is a patient in the hospital, it's the newborn's identification label. If the baby or child is not a patient in the hospital, it must have her identification label on it. We can't have milk with no label. And then that label needs to have the date and time that the milk was expressed. When you're providing a patient with labels, please make sure that the nurse and the patient verify that the labels are correct. When it comes to storage, this is going to be, I think, a big shocker. Don't put it on ice. Milk is safe out on the counter. 4 hours is ideal, but up to 8 is acceptable. It should be in a refrigerator at her bedside once it's labeled, or, as I said earlier, in a cooler bag with an ice pack where it's safe for 24 hours. Her family should be collecting that milk and taking it home for the baby. So, pump kit hygiene. So we talked about her pumping, and we talked about her storage and her labeling. And after every pump session, it's really important that she cleans her pump kit properly. So I'm going to share what happened. They revised the guidelines a few years ago. If memory serves, this was in Texas, but it was April of 2016. There was a 29-weeker born, very low birth weight. In the NICU, the baby was getting mother's milk and donor milk, was never fed formula. The mom was pumping at home with her personal pump, and she was pumping in the hospital with the hospital pump. At about 3 weeks, the baby had increasing episodes of apnea and bradycardia, showing signs of sepsis. Blood cultures and CSF cultures were positive for Chronobacter sakazakii. This is a common contaminant of powdered milk formula. Baby was treated with antibiotics, and you could see the baby was devastated, ending up with a shunt and a G-tube. So the CDC conducted an investigation to find the source of contamination. So what did they look at? The pump kit she used at home, the pump kit she used in the hospital, milk that was frozen at home, milk she used her hands to express. They cultured her nipple cream. They cultured the milk fortifier, the caffeine, vitamin D, and iron supplements the baby was getting. They looked at the tap water, faucet, and sink in the hospital. They looked at the tap water, faucet, and sink at home. They looked at the wash basins from her home kitchen, and they even looked at her stool. They found it. It was in the valves of the breast pump kit that she used at home. It was in 11 frozen milk samples that she pumped at home during 7 separate days before the onset of illness. And it was in the drain of her kitchen sink. When they talked to her about her pump kit hygiene, they discovered that what she was doing at home was different than what she was doing at the hospital. And that improper hygiene contaminated her milk. So in the hospital, she was immediately washing, letting dry, and store her pump kit parts. And they were not going into the sink. At home, she would fill the sink, drop everything in, let it soak. So the CDC revised their pump kit guidelines as a result. And these are really important if you're taking care of a lactating patient, that she knows that caring for her pump kit is important. Taking all the pieces apart that have come in contact with the milk, rinse each piece in cool water to get the milk off. Then you wash each piece separately in warm soapy water in a separate basin. Rinse it well, place everything on a blue chucks to air dry, and keep it apart until it's ready to use. Medela breast pumps, which are the brand of pumps that we have in this hospital, they accumulate condensation in the tubing, so we need to run the breast pumps with just the tubing attached for a few minutes after each pump session to get the condensation to dry out. We never put pump parts in the sink or on the floor. And when she's home, she should be sanitizing her pump parts daily. You can use boiling water, you can use a bottle sanitizer, you can use steam bags that they have for sanitizing. And that's all until the baby's about 3 months old. Okay. One of the things that we encounter a lot as a result of separation and changes in breast milk removal is mastitis. And in 2022 and 2023, the Academy of Breastfeeding Medicine revised their protocol. And they're really looking at mastitis as a spectrum, all the way from engorgement to abscess. Again, mastitis is an infection in the breast. So sort of generally, engorgement is the bilateral increasing swelling of the breasts. It's most commonly associated with large IV fluid volumes during delivery, especially section delivery, and it's associated with formula supplementation. What can we do to prevent engorgement? Keeping families together, regardless of how old the baby is, hand expressing, not using nipple shields, and unrestricted breastfeeding. What we do to help this situation of engorgement is we use ice and NSAIDs. We want to make sure we have effective breastfeeding by the baby's cue. We can hand express with or without a technique called reverse pressure softening that the lactation consultants do to soften a nipple to help milk flow. And lymphatic drainage massage. Some of the things that we want to avoid when someone is engorged is pumping if she's breastfeeding. That's a very common question. My breast is full, my baby just ate. Should I pump also? No. Don't use heat. Probably the biggest go-to thing right now, my breast is full. Put a hot pack on it. We don't want to use heat. And we don't want to massage too deeply. When engorgement is managed appropriately, it shouldn't progress. If it does, we can get plugs and inflammatory mastitis. So what's the difference? So probably the biggest difference is that engorgement is bilateral, where plugs and inflammatory mastitis are unilateral. You have one breast, very firm, swelling, lots of pain. There could be systemic signs, fever, chills, body aches. This prevention is the same and managing engorgement. The treatment do's are the same, and the treatment don'ts. So we want to avoid excessive pumping, avoid repeatedly breastfeeding on that painful breast. Don't try extra pumping on the affected breast. Don't use heat, and don't massage too deeply. Even though it's inflammatory mastitis and it might get that name, it may resolve spontaneously and may not require antibiotics. But if that happens, and we do sometimes get women come in with mastitis, there's worsening symptoms. These women are pretty sick. They really don't feel well. And again, prevention is optimal management. We can get ahead of this earlier by following the guidelines early. And I think the biggest thing here is the treatment don'ts, because the treatment don'ts are the things that we have done historically, which is try to get the milk out. So when someone has pretty significant mastitis, their breast is so swollen that the milk doesn't move, it doesn't come out. And what we've done in the past is really kind of dig in there, use our hands, massage deeply, try to express the milk. And what we've learned is that is not helpful. It damages her tissues, it worsens inflammation, as does the heat. So what we want to try to do is leave that breast be and ice it, and then ice it again. And once the swelling goes down, then we can start expressing the milk again. These people need antibiotics. Okay, I'm almost done. This is a big one. So please tell me what you think. IV contrast media is not safe, and you have to pump and dump for 24 hours after an MRI or a CAT scan with IV contrast. So do you think that's true or false? I am so proud of everybody right now because that is false. Yay, excellent job. Most medications are compatible with breastfeeding. Most antibiotics, most SSRIs, most pain medications, most diagnostic contrast media, heparin, Lovenox. Try to forget the pump and dump. It is perfectly appropriate to be unsure, and you're not an expert in this area, and you might not know. I don't know if she can give this milk with this medication. So we don't throw it out, we just save it. We put the reason why we think it might not be safe on the side, and then me or someone from my team can come and go through what she needs to know to make an informed decision about providing her milk with that medication. The decision, this is important, the decision to provide the breast milk to the baby is hers in conjunction with her pediatric provider. The radiology tech doesn't decide that she throws out her milk. I don't decide that she throws out her milk. The mother gets to decide what happens with her milk. And straight out of the American College of Radiology's manual on contrast media, because of the very small percentage of iodinated contrast medium that's excreted into the breast milk and absorbed by the infant's gut, we believe that the available data suggest that it is safe for the mother and infant to continue breastfeeding after receiving such an agent. Same goes true for the gadolinium-based contrast. So for pediatric visitors, meaning the mom comes in and her child is with her but not a patient, avoiding separation is valuable. I know sometimes this is tough. It seems like the baby's in the way or she's not getting any rest, but it really is important for them to stay together. And the younger the baby, the more vital that non-separation is. What's important to know, though, is that that admitted patient can never be left alone with the child or the baby. A dedicated caregiver from her family must be there to meet all infant care needs. And the staff in the hospital are not responsible for the care of that baby. So some of the things that we might want to think about to improve our patient experience is to screen women of childbearing age for lactation needs when there's a planned surgical procedure. You might want to think about asking for a small dorm fridge for your unit. If somebody wants a resource binder for their unit about caring for a lactating patient, let me know. I'd be happy to work with you and create that. If you need a lactation consultant, you can order one on Sunrise. How cool is that? It's right there, just like you're ordering a social work consult. You can order us to come. And we are not 24/7. We're 7, but we're not 24. And anytime somebody needs assistance, they can definitely email us. We have a dedicated email, nsuhlactation@northwell.edu, and that is monitored every day. And if you need information, the CATS leadership knows who's here each day. That's it for me. Does anyone have any questions? I don't know if there are questions. No? Okay. All right, thank you. Amanda, you have a question? Yes. So they can definitely email us. That email, I help people the day they go home, and then 2 years later, they're like, okay, I'm done, now what? So they can still email us. We will help them with anything that they need. There's a great site, just Lactation Education Resources is a very reputable site, and they have a lot of patient handouts that are evidence-based, and there's something for everything, and that is definitely on there. But if somebody needs something, they can reach out to us, and we will always help them. Thank you. And I just revamped our employee lactation information because the hospital got 2 new Mamava lactation pods, which are beautiful and it's great. Everybody's super happy. But employee lactation needs, definitely reach out. We're here to support everybody, not just our patients. And a plug.